If your doctor handed you a prescription for sertraline when you walked in complaining about crushing fatigue at 47, you were not crazy and you were not clinically depressed. You were almost certainly iron deficient, estrogen depleted, or both, and nobody ran the blood work that would have told you that in 15 minutes. I know this because I see the aftermath of that exact failure every single week in my clinic. Women who lost 2 or 3 years to an SSRI that never addressed the actual biochemical collapse happening inside their bodies. The antidepressant did not fix the insomnia, because the insomnia was not driven by serotonin. It was driven by estradiol falling off a cliff. The antidepressant did not fix the brain fog, because the brain fog was not anxiety. It was ferritin sitting at 19, while her doctor told her the labs looked normal. The antidepressant did not restore her libido, because libido in a perimenopausal woman is governed by testosterone and estrogen, not by selective serotonin reuptake inhibition, which in many cases actually suppresses sexual function further. If you are sitting here right now thinking that sounds exactly like what happened to me, stay with me, because I am going to walk you through the precise clinical sequence that should have happened at that first appointment and did not. What I am about to share is not theory. It is the standard of care I practice daily, rooted in the strongest endocrine evidence we have. I am Dr. Lisa Sheld, a board-certified gynecologic endocrinologist with NAMS certification and 19 years of clinical practice treating women in perimenopause and postmenopause exclusively at the Meridian Women's Endocrine Center in Charlotte, North Carolina. My clinic has managed over 11,000 women between the ages of 40 and 65 through individualized, evidence-based hormone therapy guided by the NAMS 2022 position statement, the timing hypothesis validated by the ELITE trial, and metabolic data from the KEEPS trial. I trained alongside researchers who contributed to KEEPS, and I have integrated clinical frameworks from Dr. Mary Claire Haver's menopause metabolic work and Dr. Louise Newson's large-scale symptom tracking data from the United Kingdom. I do not sell supplements, I do not operate a hormone mill, and I do not post on social media to move product. Every protocol I share today is exactly what I tell my own patients when they are sitting across from me in a consultation room with their labs in my hand. My practice philosophy is straightforward. Test thoroughly, treat precisely with pharmaceutical-grade hormones in evidence-based delivery systems, and never dismiss a woman who tells you something has fundamentally shifted inside her body. I hold additional certification in sexual medicine because I refuse to let a woman leave my office without addressing the symptoms she was too embarrassed to bring up with her last provider. What I am about to give you is not wellness advice. It is clinical endocrinology practiced at the standard these patients deserve and rarely receive. Here's the reality that should make you furious and then motivated. A 2021 survey published in Menopause, the Journal of NAMS, confirmed that the average American medical school devotes fewer than 2 total hours of curriculum to menopause management across 4 years of training. That is not a typo. 2 hours to cover a biological transition that affects every single woman who lives past 50 and produces symptoms severe enough to impair daily function in roughly 75% of them. This is not your family doctor's personal failure. It is a catastrophic gap in medical education that has persisted for decades, while cardiovascular training gets hundreds of hours. The downstream consequence is predictable and devastating. Your general practitioner was never taught to interpret a perimenopausal hormone panel, was never trained on transdermal estradiol dosing, and was almost certainly taught to fear hormone therapy based on a misrepresentation of the 2002 Women's Health Initiative data. That WHI headline, the one that told the world HRT causes breast cancer and heart attacks, was based on a study population with a mean age of 63, many of whom were a decade or more past menopause onset, using oral conjugated equine estrogen plus synthetic medroxyprogesterone acetate, a formulation and timing strategy that no informed menopause specialist would replicate today. For women who initiate therapy within 10 years of menopause onset using transdermal estradiol and micronized progesterone, the data from ELITE and KEEPS show a fundamentally different risk-benefit profile, including potential cardiovascular protection and significant quality of life improvement. But that nuance never made the evening news, and an entire generation of physicians internalized the fear without ever revisiting the evidence. The result is that millions of women between 45 and 55 are being undertreated or completely untreated during the exact window when intervention is safest and most effective. Let me tell you about a patient I will call Catherine, because her story is the one I hear most often, and it captures exactly how the system fails perimenopausal women. Catherine was 49, a project manager in Charlotte, married, 2 teenagers, exercising 4 days a week, eating well, doing everything she was supposed to do. Over about 14 months, she developed progressive fatigue so severe she started setting alarms to remind herself to pick up her kids because her brain could not hold a simple schedule anymore. She was waking at 3 in the morning, drenched in sweat, her heart pounding at 95 beats per minute for no reason, and she had not wanted to be touched by her husband in over a year, which was destroying a marriage that had been solid for 2 decades. She went to her family doctor, who ran a CBC that showed a hemoglobin of 118, just 2 points below the female reference cutoff of 120, and a TSH that was normal. No ferritin was ordered, no estradiol, no FSH, no free testosterone, no SHBG, nothing that would have revealed the hormonal collapse that was driving every single one of her symptoms. Her doctor told her the blood work looked essentially fine and suggested she try magnesium for sleep, maybe a short walk after dinner for stress, and offered a referral to a therapist for the low libido. Catherine sat in her car in the parking lot afterward and cried, not because she was depressed, but because she knew something was biologically wrong, and the person she trusted most to find it had just told her she was basically fine. 18 months later, Catherine landed in my office, referred by a friend who had gone through a similar experience. By then, her periods had become wildly irregular, flooding for 9 days every 3 weeks, which is textbook late perimenopause, when estrogen surges erratically before its final decline. That uncontrolled heavy bleeding had been silently draining her iron stores for over a year, and when I ordered the panel her previous doctor never ran, her ferritin came back at 14. 14, in a lab that flagged low only below 12, which meant her result was technically marked as normal, even though current evidence, including a 2022 consensus from the British Society of Gastroenterology, supports that symptoms of iron deficiency begin when ferritin drops below 30, and optimal function for most women requires levels above 50. Her estradiol was 22 picograms per milliliter, which is postmenopausal range. Her FSH was 68, and her free testosterone was barely detectable at 1.2 picograms per milliliter. Every symptom she had, the fatigue, the cognitive collapse, the insomnia, the palpitations, the absent libido, the hair falling out in the shower, had a clear, measurable, treatable biochemical cause sitting right there in her blood work. Nobody had looked, and she had lost almost 2 years of her life to a system that was not equipped to evaluate what was happening to her. I want to be very clear about something, because I am not here to vilify primary care physicians. I am here to name a structural problem so you can navigate around it. Catherine's family doctor is a competent clinician who manages diabetes, hypertension, and acute illness with skill and dedication. The failure was not intelligence or effort, it was training. When you receive fewer than 2 hours of menopause education in medical school and your residency program never rotates you through a menopause clinic, you do not develop the pattern recognition to see that a 49-year-old with heavy periods, insomnia, palpitations, and low libido is presenting a textbook perimenopausal hormone deficiency syndrome, not a stress disorder. You default to what you were taught. Rule out thyroid, check a CBC, and if those are normal, consider psychiatric referral. That algorithm misses the diagnosis in the majority of perimenopausal women because it was never designed to catch it. Menopause medicine is a distinct subspecialty that requires dedicated training, and the NAMS certification exists precisely because the gap between general medical education and competent menopause management is enormous. This is why I tell every woman in my practice, if your provider has not completed NAMS certification or equivalent menopause-specific training, you need a second opinion from someone who has. Not because your doctor is bad, but because this is not their area of expertise. What happened to Catherine after she walked into my clinic is exactly what should have happened 18 months earlier, and it is exactly what I am going to teach you to demand for yourself. I started her on 2 simultaneous tracks. Aggressive iron repletion, because you cannot restore energy, cognition, or exercise tolerance when your ferritin is 14, and a carefully dosed transdermal estradiol plus micronized progesterone regimen, because her ovarian hormone production had effectively collapsed. Within 6 weeks, her night sweats had stopped completely. Her sleep architecture had normalized to the point where she was sleeping 6.5 continuous hours for the first time in 2 years, and her resting heart rate had dropped from the mid-90s to 72. At 12 weeks, her ferritin had climbed to 41. Her brain fog had lifted enough that she stopped using reminder alarms, and she told me, with tears in her eyes, that she had felt desire for her husband for the first time in over a year. At 6 months, I added low-dose compounded testosterone because her free testosterone was still suboptimal. And within another 8 weeks, she described her cognitive sharpness and physical energy as better than they had been at 40. This is not a miracle story. This is what happens when you identify the correct deficiencies and treat them with the correct agents at the correct time. I need you to understand that Catherine's outcome is not exceptional. It is expected when the diagnosis is made properly and the treatment follows current evidence. The tragedy is not that we lack effective therapies. We have had transdermal estradiol for decades, micronized progesterone since the PEPI trial in 1995, and growing data supporting testosterone for hypoactive sexual desire in postmenopausal women from the Global Consensus Position Statement on Testosterone Therapy, published in 2019. The tragedy is that millions of women between 40 and 60 are never offered these therapies because their providers were taught to fear them based on outdated, misapplied data, or were never taught about them at all. A 2023 analysis in The Lancet confirmed that up to 30% of perimenopausal women with iron deficiency anemia go undiagnosed because clinicians attribute their symptoms entirely to aging or mood disorders. And a parallel NAM survey found that fewer than 1 in 5 women experiencing moderate to severe menopausal symptoms had been offered hormone therapy by their primary care provider. That means 80% of women who could benefit from a well-established, evidence-based treatment are walking around symptomatic, exhausted, cognitively impaired, sexually absent, and convinced that this is just what getting older feels like. It is not. And I refuse to let that stand unchallenged in any conversation I am part of. In the next section, I am going to give you the exact blood panel to request at your next appointment, including the specific ferritin threshold that actually matters, and the 4 hormone levels that reveal whether you are in perimenopause. And then I am going to walk you through the first-line transdermal estradiol plus micronized progesterone protocol I start most of my patients on, with doses, delivery systems, and the timeline for when you should expect to feel different. First protocol for perimenopausal women with fatigue, hair loss, and restless legs. Get a serum ferritin test today, not just a CBC, and treat aggressively if your ferritin is below 30, regardless of whether your hemoglobin looks normal on paper. Request a complete iron panel, serum ferritin, serum iron, total iron binding capacity, and transferrin saturation alongside a full hormone panel including estradiol, FSH, free and total testosterone, SHBG, and thyroid function with TSH and free T4. If your ferritin comes back below 30, begin oral ferrous bisglycinate at 25 milligrams every other day rather than ferrous sulfate, which causes significantly more constipation and gastrointestinal distress at the standard 325 milligram dose that most doctors reflexively prescribe without thinking twice about tolerability. Take it with 200 milligrams of vitamin C on an empty stomach to enhance non-heme iron absorption by up to 3-fold through reduction of ferric iron to the more bioavailable ferrous form. Avoid coffee, tea, calcium supplements, and dairy within 2 hours of your iron dose because tannins and calcium directly inhibit iron absorption at the enterocyte level in your small intestine. If you cannot tolerate oral iron after 6 weeks, or if your ferritin is below 15 with symptomatic anemia, including shortness of breath and tachycardia, ask your doctor about intravenous iron. Specifically request monoferric, which is ferric direisomaltose, because it delivers a full repletion dose of 1,000 milligrams in a single 1-hour infusion, rather than requiring multiple sessions. The difference between ferrous bisglycinate and ferrous sulfate is not trivial. Bisglycinate is chelated, causes dramatically fewer gastrointestinal side effects, and absorbs well even without the acidic gastric environment that sulfate depends on. Iron is the essential cofactor in hemoglobin's oxygen-carrying capacity and in mitochondrial electron transport chains that generate cellular energy throughout your brain, muscles, heart, and every tissue that matters for daily function. When ferritin drops below 30, your body has exhausted its storage reserves, even if your hemoglobin is still hanging on at the low end of normal. This is called iron deficiency without anemia, and it produces the same crushing fatigue, cognitive fog, hair shedding, and restless leg syndrome that full-blown anemia does. Perimenopausal women are uniquely vulnerable because fluctuating estrogen levels cause unpredictable and often dramatically heavier menstrual bleeding, sometimes flooding through a super tampon in under an hour, that accelerates iron loss precisely when compensatory mechanisms are already stressed by hormonal chaos. Your bone marrow is desperately trying to manufacture red blood cells, but it cannot build hemoglobin molecules without adequate iron. So it sends out smaller, paler red blood cells that carry less oxygen per trip through your circulatory system. This is why you feel winded walking up a single flight of stairs, even though you ran half marathons 5 years ago. Your oxygen delivery infrastructure has been quietly dismantled from the inside. The GABA agonist properties of micronized progesterone, which I will detail in the next protocol, also help regulate the dysfunctional uterine bleeding that is draining your iron in the first place. Progesterone stabilizes the endometrial lining so you stop flooding, which directly reduces ongoing iron loss and allows your repletion efforts to actually gain traction instead of running on a treadmill. Every month you bleed heavily without replacing iron is another month your ferritin drops lower, and your symptoms compound on themselves in a vicious cycle that willpower alone cannot break. Do not supplement iron without testing first. Hemochromatosis, a genetic iron overload condition affecting roughly 1 in 200 people of Northern European descent, can cause liver damage, diabetes, and heart failure if iron is added blindly to someone who already has too much. Women with inflammatory bowel disease, celiac disease, or prior gastric bypass surgery will likely need IV iron because oral absorption is severely compromised by mucosal damage or reduced intestinal surface area. If you are currently being evaluated for unexplained iron deficiency over the age of 50, your doctor should order a colonoscopy to rule out colorectal malignancy before simply treating the deficiency and moving on. Iron deficiency in a postmenopausal woman who is no longer bleeding is a red flag that demands investigation, not just supplementation, because the blood is going somewhere and you need to find out where. Women on anticoagulants or with known bleeding disorders should coordinate iron repletion closely with their hematologist to ensure the underlying blood loss is being managed simultaneously. If you have a peanut allergy, be aware that some oral iron formulations, and even certain IV preparations, contain additives that may trigger a reaction. So read labels carefully and inform your infusion nurse. Chronic kidney disease patients often have complex iron metabolism that requires nephrologist oversight because erythropoietin dynamics change the entire repletion calculation. The bottom line is simple. Test before you treat, identify why you are deficient, and then replete aggressively with the right formulation for your specific clinical situation. Recheck ferritin at 12 weeks for oral supplementation and at 4 to 6 weeks after wine V infusion. You should notice measurable improvement in energy, hair shedding, and restless legs within 6 to 8 weeks of adequate repletion if the underlying cause has been addressed. A 2023 New England Journal of Medicine trial confirmed that wine V ferric diisomaltose produced significant fatigue reduction within 4 weeks in iron-deficient women, even without frank anemia on their blood count. NAMS 2022 guidelines emphasize that iron status must be evaluated as part of any comprehensive perimenopausal workup because untreated deficiency confounds the clinical picture and blunts the full benefit of hormone therapy. You cannot optimize estradiol, progesterone, and testosterone on top of a ferritin of 14. Your mitochondria need iron to convert those hormonal signals into actual cellular energy production. The British Society of Gastroenterology's 2021 updated guidelines support a ferritin target of above 50 for symptomatic women, not the outdated cutoff of 12 that many labs still use as their lower reference limit. If your lab report says your ferritin is normal at 15, that lab is using a threshold designed to detect severe depletion, not to identify the functional deficiency that is causing your symptoms right now. Aim for a ferritin above 50, ideally between 50 and 100, and recheck every 3 to 6 months until you are stable, especially if you are still menstruating and losing blood cyclically. Iron repletion is not a one-time fix. It is an ongoing management strategy that must account for your menstrual pattern, dietary intake, and absorption capacity until you reach menopause and the monthly losses stop. Now that we have addressed the iron foundation, because no amount of estrogen will fix you if your ferritin is on the floor. Let me give you the exact hormone replacement therapy protocol that sits on top of this and transforms everything. If you are watching this and thinking this is the first time anyone has connected iron deficiency to perimenopause to hormone therapy in a single, coherent clinical sequence, subscribe right now because every week on this channel, I break down one specific menopause protocol with the same precision your doctor should be giving you, but almost certainly is not. Here is the complete regimen I initiate for the majority of my symptomatic perimenopausal and early postmenopausal patients. And I want you to write down every single word, because this information could reshape the next decade of your life. Start with transdermal estradiol, a patch delivering 0.05 milligrams per day, brand names Viveldot or Climera, applied to the lower abdomen or inner thigh, rotating application sites with each change to prevent skin irritation. Replaced twice weekly for Viveldot or once weekly for Climera, depending on which your pharmacy carries and your insurance covers. Transdermal delivery bypasses hepatic first-pass metabolism completely, which means it does not increase clotting factors, does not raise triglycerides, does not elevate sex hormone-binding globulin the way oral estrogen does. And the KEEPS trial demonstrated equivalent symptom relief with superior cardiovascular and metabolic safety profiles compared to oral conjugated equine estrogens. Add micronized progesterone, brand name Prometrium in North America, Utrogestan in Europe and the United Kingdom, at 100 milligrams orally every night at bedtime if you still have a uterus, swallowed whole with a small amount of food, never split or crushed because the micronization is what controls the absorption kinetics. This is bioidentical progesterone, structurally identical to what your ovaries produced before perimenopause, and it acts as a potent GABA-A receptor agonist through its neurosteroid metabolite allopregnanolone. This is why it makes you sleepy. This is why it calms the 3 a.m. anxiety, and this is precisely the mechanism that synthetic medroxyprogesterone acetate does not share, because MPA does not convert to allopregnanolone. Think of micronized progesterone as a gentle neurological brake that simultaneously protects your endometrium from estrogen-driven hyperplasia and delivers a sedative effect that replaces the benzodiazepine, or zolpidem, your previous doctor probably offered you. One agent doing 2 critical jobs instead of stacking pharmaceuticals that each carry their own dependency risk. If you have a peanut allergy, Prometrium's capsule contains peanut oil, so you will need a compounded micronized progesterone in a different oil base from a reputable compounding pharmacy. Do not skip progesterone entirely just because of this allergy. Find the alternative formulation. Contraindications for systemic estradiol include current or recent estrogen receptor-positive breast cancer, which requires oncologist collaboration before any consideration. Active venous thromboembolism, where transdermal is actually safer than oral, but still requires hematology input. Severe active liver disease, and undiagnosed vaginal bleeding that has not been evaluated with ultrasound and endometrial biopsy. For women with persistent low libido, cognitive dulling, muscle loss, or fatigue that does not fully resolve with estradiol and progesterone alone after 3 months of optimized dosing, I add testosterone cream compounded at 0.5 to 1 milligram per day, applied to the inner thigh or labia majora, rotating sites, prescribed through a compounding pharmacy because no FDA or EMA-approved testosterone product for women currently exists at physiologic female doses. The Australian Monash University Consensus and the 2019 Global Position Statement published in the Journal of Clinical Endocrinology and Metabolism confirmed that testosterone therapy at physiologic female doses, targeting a free testosterone in the mid-normal premenopausal range, significantly improves sexual desire, arousal, orgasm frequency, and overall psychological well-being, with a favorable safety profile and no increased cardiovascular or breast cancer risk at these doses. If you develop acne, oily skin, or new facial hair growth, your dose is too high and needs reduction. These virilization symptoms are dose-dependent and fully reversible when the dose is adjusted downward, so they are a signal to calibrate, not a reason to abandon treatment entirely. Monitor with a follow-up hormone panel at 3 months after initiation. estradiol level aiming for 60 to 200 picograms per milliliter, depending on symptom response. Progesterone level confirming absorption. Free testosterone in the premenopausal reference range. SHBG to ensure it is not being suppressed or elevated in ways that alter free hormone availability. And a repeat ferritin to confirm your iron repletion is holding alongside your hormonal optimization. The ELITE trial proved that estrogen initiated within 6 years of menopause onset slowed carotid artery intima media thickness progression, meaning it was actively cardioprotective, while estrogen started more than 10 years after menopause showed no such benefit, confirming the critical importance of the timing hypothesis that should govern every prescribing decision. Night sweats typically resolve within 2 to 4 weeks of adequate transdermal estradiol dosing. Sleep architecture normalizes within 3 to 6 weeks as progesterone's GABA agonist effect accumulates. Libido and sexual function improvements from testosterone emerge at 8 to 12 weeks, and vaginal tissue restoration from local estrogen takes 4 to 8 weeks of consistent application. I have watched women who spent years telling themselves they were simply aging and losing themselves come back to my office at the 3-month follow-up, sitting straighter, speaking faster, laughing more easily, and telling me they feel like the person they thought was gone forever. That is not magic. That is what happens when you identify the correct biochemical deficiencies and treat them with the correct agents in the correct delivery systems at the correct time in a woman's life. You deserve to feel like yourself again. Not a diminished, exhausted, invisible version of the woman you know you still are inside. And the science to get you there has existed for years, while the medical system failed to deliver it to you. If this video gave you clarity you have been searching years for, subscribe to this channel and turn on notifications so you never miss a protocol. Drop a comment below with your age, your top 3 menopause symptoms, and whether you have ever had a full hormone panel, because I read every single comment, and I will address the most common patterns in upcoming videos. I have created a free menopause symptom tracker plus hormone test checklist PDF. The link is pinned in the comments and in the description. Print it out, fill it in before your next appointment, and hand it to your doctor so the conversation starts with data instead of dismissal, and you never again leave an office crying in your car because nobody listened. Go to menopause.org and use the Find a NAM certified practitioner tool to locate a provider near you who actually understands the difference between medroxyprogesterone and micronized progesterone, between oral conjugated estrogens and transdermal estradiol, between dismissing your symptoms and treating them. Because that distinction is the difference between losing 5 more years and getting your life back starting this month. If you are outside North America, search for a British Menopause Society certified specialist in the UK or an Australasian Menopause Society practitioner in Australia and New Zealand. Equivalent organizations exist in most countries, and their provider directories are free to access online. Share this video with one woman in your life who you suspect is suffering silently through perimenopause. Your sister, your colleague, your mother, your best friend. Because the information in this video could be the thing that finally makes her realize she is not broken. She is biochemically depleted, and there is a precise, evidence-based path back to herself.